Welcome everybody in our Saudi Society for Blood Disorders webinars. My name is Dr. Amal Bihani. I'm a consultant hematologist and bone marrow transplant from King Faisal Specialist Hospital, Medina. I'm the Vice President of Saudi Society for Blood Disorder. I would like to welcome you and thank you all for joining us in this webinar series. This series for this time will cover the best of ASCO EHA 2021, and it will be a series of 4 webinars. The first one is, cannot flip my slide, is today's, and it will have 3 speakers. It's supposed to be 4 speakers. Dr. cannot flip my slide, sorry. Dr. Saud Al-Haili, apologize. Sorry, I will share my slide again. It's 4 webinars. I don't know why can I not flip my slide. So the first webinar, sorry, today it will be about multiple myeloma and plasma cell dyscrasia, and we will have a weekly session. The second session will be next week, and it will be lymphoma and chronic lymphocytic leukemia. And 24th of September, we will have leukemias and myelodysplastic syndromes. And on the 1st of October, we will have the cellular and immunotherapy. For our webinars today, as I mentioned, it will be about the multiple myeloma and plasma cell dyscrasia, and it will have 2 speakers, in addition to 1 satellite symposium. The satellite symposium is sponsored by Janssen. Thanks for Janssen, actually, for continuous support for our society and for most of the society to support the educational activities. Just a reminder that the webinar series will be recorded, and you can, it will be available through our YouTube, and you can follow us in our social media site through YouTube, Twitter, and in addition, we are very glad in launching our educational Arabic website, which is Salam al-Damak. So we are encouraging you to invite your patient, your families, and the public and the community to access this site. So it's my pleasure to introduce the first speaker, who is Dr. Majid Al-Ahmadi. Dr. Majid Al-Ahmadi is a consultant hematologist and bone marrow transplant from Princess Noura Oncology Center in Jeddah. Majid has a special interest in myeloma and lymphoid malignancies, and in his talk will present for us best of ASCO EHA upfront therapy in multiple myeloma. Please, Majid.
Assalamu alaikum wa rahmatullah. Thanks, Dr. Amal, for the introduction, and I would like to thank the SSBD for inviting me for this important event. Today I will try to summarize and give you some of the updates about upfront therapy in multiple myeloma. So it's a difficult task to talk about this in only 20 minutes. So I'll try to be concise as much as possible, and we'll have some time for discussion at the end. So as everyone knows, that multiple myeloma is one of the non-curable blood cancers. So basically, the fight with this cancer is a long term, and we have to be very smart in terms of what the best strategy to treat the patient and balance between the benefits and toxicities. So before you start your patient therapy, it should be very clear in your mind what you want from this therapy. And I think one of the most important goals when you are treating patients with multiple myeloma is you are trying to make his life better. And if that did not happen, I think we are not achieving the proper goal of therapy. Beside that, we would like to make the patient, inshallah, live longer and prevent organ damage, as everyone knows. So that's why it's very important to balance between the risks and the benefit. You have to assess the patient and choose your therapy wisely. We will not focus only on deepen the response, but also we have to look at the patient as a whole. So before you start your patient on therapy, you have to assess their disease risk, and you need to assess their eligibility for stem cell transplant. And I think most of you knows the ways of assessment the disease risk by either the M-SMART criteria, so based on their fish cytogenetics, RISS stage, high plasma cell S-phase, if that's available, and gene expression profiling also, if that's available, though it's limited. So if the patient has any one of these chromosomal abnormalities, he will be automatically considered as a high risk. Furthermore, if he has more than one, then you are dealing with the double hit or triple hit myeloma, and these cases are difficult and very challenging, and you have to be more aggressive in the therapy. Also, one of the modules that widely used is IMWG modules, and that will classify the patient to high risk, standard risk, or low risk based on these criteria. Also, the IF module, the same thing, will classify the patients based on their risk status. So, and after that, you need to assess your patient's eligibility for transplant based on age, performance status, and comorbidities. So the patient will be either transplant eligible or non-eligible. So if you deemed your patient as transplant eligible, the roadmap that you will use is usually starting with induction, trying to control the disease and put it in remission as deep as possible. After that, you would consider either one transplant versus two transplant, and then some controversies about consolidation, so consolidation or no, although some data showing that consolidation will deepen the response more and put the patient more into the negativity, and then you would go with maintenance therapy. But now, with all of the novel agents and improvement in the induction therapy that we have, you might question, for a standard risk patient, should I go for transplant or not? And we will try to answer this during this talk. So which induction you would use? So your induction has to be fast. You need to control the disease as quick as possible. It should be safe. It should be well tolerated, and it should be affordable and available in your center. And if you are aiming for transplant, your induction should not affect the stem cell collection much. So usually, any induction would be made of a proteasome inhibitor, which is either bortezomib, carfilzomib, steroid, either dexamethasone or sometimes prednisone, and immunomodulatory drug, which is the more commonly used than alkylator. Options like lenalidomide or thalidomide that can be considered, but for some of the patients, it's contraindicated or difficult to give immunomodulatory drugs. So you still can use alkylator like cyclophosphamide. Nowadays, we know that addition of monoclonal antibody to backbone of induction regimen has shown some improvement in outcomes. So before you start your therapy, as I mentioned, you have to assess your patient in terms of comorbidities, because that also will affect your choice of therapy in terms of organ function. And also you need to assess the patient risk status, because your induction might also be affected by the risk status of the patient. So these are some of the available inductions that we have nowadays, and I'm going to talk about some of this in detail. So CyBorD or VCD, one of the old regimen, and actually, although it's old, but still it's used until now. It is effective and well tolerated, and I think was one of the landmarks in terms of improvement in myeloma patients. Before that, there was nothing as in form of a novel therapy. Everything was used as conventional chemo or high-dose dexamethasone. So the introduction of the bortezomib to the induction resulted in significant improvement in patient outcomes, as we can see here. Although this is an old kind of regimen, but still it's effective. We can see here that PR or more is reaching close from 100%. But as you can see here, we are not seeing much of deeper responses as what we aim for nowadays. So that resulted in some changing in the backbone induction. So VRD was tested in the IFM09 trial, and I'm sure most of you know about this. So it was published now a number of years ago. So patients, so there was 700 patients were enrolled, and they were all received 3 cycles of VRD as per this protocol. And then the patients were randomized to either go for transplant or no transplant. The patient who did not go for transplant, they received 5 cycles of VRD and then 3 cycles of VRD, so total of 8 as a consolidation. And then the patient who did not did go for transplant, they put on limb maintenance, and then everyone continued on limb maintenance. So the results of this trial was quite good, and as we can see here, more than half of the patient they achieved the CR, or even more than half in the transplant group. And also, what was impressive, the significant number of people who achieved MRD negativity in both groups. But as you can see here, it was in a favor of the transplant arm. So transplantation, although there is improvement in the induction regimen, but still it showed a significant advantage. As you can see here, the PFS was better in the transplant arm. So based on that, the VRD became the standard of choice, or the preferred induction in almost many centers in our country and around the world. But can we make that better? So, well, one of the things that we can consider is adding monoclonal antibody, switching the proteasome inhibitor we were using from carfilzomib to from bortezomib to carfilzomib. Would that make any difference? And with this improvement in the induction regimen, do we still need a transplant for all standard risk patients? So I will try to answer some of these questions in the next of my slides. So the Griffin trial, which was presented in ASH about 2 years ago, they looked at answering this question. So basically, so the patients with newly diagnosed myeloma who are transplant eligible were randomized either to receive DARA plus RVD or RVD only. And then everyone went for transplant and then got the consolidation based on the therapy he received before, and then maintenance either as DARA, LEN, or lenalidomide only. So based on the analysis was presented at that time, addition of daratumumab to a backbone of RVD resulted in a deeper response. As we can see here, there is 10% difference in terms of the stringent CR between the 2 groups. And in addition to that, there was a continuous improvement. So with the addition of daratumumab to lenalidomide maintenance, the patients who were going into a deeper response in form of CR were increasing by time. Based on the analysis presented at that time, it was too early to see a significant difference in terms of PFS or overall survival. So in the ASH of 2020, the results of this trial was updated, and they published data after 12 months of maintenance. And it's still showing deeper responses in the DARA arm. So with the addition of daratumumab to lenalidomide as a maintenance, we can see here there is a difference in the number of patients who achieved stringent CR. And also there was a significant difference in terms of the patients who achieved MRD negativity. So, but the same thing still, we are not seeing significant difference in terms of the PFS, although the curves have started to split, but we will need a longer follow-up. The same concept was shown in the Cassiopeia trial, which was presented by the French group. So they used their standard induction and they add to that daratumumab. So patients were randomized to either dara-VT, VDD, or VDT. One will go for transplant, and then will get a consolidation from the drugs that he received before. And then there was another randomization. So therapy or observation. So the results initially was presented and published, and it showed a difference in terms of how deep a response we are getting. So addition of daratumumab to a backbone of VDT resulted in more deeper responses in terms of stringent CR and also more MRD negativity, as we can see here between the two arms. So that was clear by this curve, and the same thing we were seeing with time. We are getting more deeper responses, but it's more in a favor of the daratumumab arm. So in ASCO of 2021, the Cassiopeia Part 2 results were presented. So basically, they were looking at the benefit of daratumumab maintenance in patients who already received induction, transplant, consolidation, and they were randomized to either receive daratumumab maintenance versus observation as a placebo. And the results were presented, and it showed that the use of daratumumab maintenance, which is expected, associated with longer (46.10). And the same thing was seen in the time to progression. But it's important to say that the benefit of daratumumab maintenance was patients mainly receive VDD. So patients who received DAR-VDD, they did not show significant improvement with daratumumab maintenance. So that's an important thing to observe in this trial. So the question that I will raise here, so switching the PI were using from bortezomib to carfilzomib. So this was actually tested and shown in the endurance trial, which also was presented in the ASCO of the last year. So patients with a newly diagnosed multiple myeloma who are considered as transplant eligible, they excluded patients with high risk cytogenetics like 7, but included patients with translocation 414 or 411. And the aim here was to go with induction strategy and does not necessitate going for transplant right away. So that basically the concept of this trial. So as we can see here, so the patients were randomized to receive either the standard VRD or go with this newer regimen, the KRD, and then another randomization, which still we don't know about, with either maintenance of lenalidomide indefinitely or maintenance or progression or for a specific period of time until 24 months. So basically, one of the things that we have to observe in this trial that there are many patients did not receive the therapy that they intended to for various reasons, as we can see. So that's something you have to put in your consideration. So in this trial, despite using carfilzomib, that did not translate it into clinical benefits. So the PFS was quite similar between the two arms, as well as the overall survival. And that was clear among all the subgroup analysis. And as I mentioned to you, they did not include patients who are 17p in this trial. And as we can see here, there was a trend of deeper responses with KRD, but more or less it was quite similar. The same thing, overall survival was the same, and toxicity-wise was more in a favor of VRD. So VRD was better tolerated. There was more grade 3 and grade 4 toxicities with the KRD arm. And we can see here, most of the toxicities were more common in the KRD, but peripheral neuropathy was more evident in the patients who received VRD. So as we can see here, more peripheral neuropathy, but more cardiac and renal complications. So basically the conclusion of this trial that KRD did not improve PFS or overall survival in comparison to VRD. So VRD still a standard of care. So the other question that I want to ask here is, do we need to go for transplant for every patient? So that was also tested and presented in ASCO last year. So looking at patients who are newly diagnosed multiple myeloma, transplant eligible, and they received induction of KCD, so carfilzomib, cyclophosphamide, dexamethasone, 4 cycles, and then the patient were randomized into one-to-one protocol to either go for transplant or to go with consolidation of another 4 cycles of KCD, and then everyone will go for carfilzomib maintenance for 18 months. So the patients who underwent transplant had a better PFS, which was not reached. But in terms of the patients with high-risk cytogenetics, transplant did not result into a significant improvement in terms of PFS. So the high-risk cytogenetics was associated with poor outcomes, regardless transplanted or not in this trial. But the more of the advantage was in the standard risk. So MRD negativity was shown to be better in the transplant arm rather than the consolidation arm. So the conclusion from this trial that KCD induction and K maintenance with the KCD consolidation was non-inferior to transplant, but and people with high risk cytogenetics, they did poorly regardless which therapy they received. So in terms of the transplant and eligible, I will present some data here quickly. So the alkylator was the standard of care a while ago until the introduction of novel therapies, which was used in these group of patients. So the VISTA trial, which was presented now a number of years ago, which showed improvement with addition of bortezomib to a backbone of methylprednisolone, and we can see here the difference in terms of PFS between the two arms. So can we make that any better? So the same thing was applicable here. So addition of daratumumab to a backbone of VMP resulted in improvement in the patient's outcome in terms of PFS. So we can see here at 42 months, there was a difference in terms of PFS in the DARA group versus VDT only. That also was associated with the deeper responses, as we can see here, more stringent CR, and also more MRD negativity, as we can see here. And that was translated into a survival benefit, as you can see here as well. So IMiD-based, so the first trial, which was presented now a number of years ago, looking at this question, and it showed that using RD continuously associated with a better outcome in terms of PFS, and even overall survival. But can we make that any better? So the data now presented a few years ago, and it was presented or updated recently, the Maya trial. So looking at addition of daratumumab to a backbone of Lendex, and that actually was resulted in improvement in the patient's outcomes. So we can see here in the first analysis, which was presented in ASH of 2018, DARA RD PFS was not reached, but it was 31.9 in the RDR. So survival also was better in terms of patients who received DARA RD, as we can see here as well. And as well as significant or impressive, I should say, MRD negativity. So 90% of the patients who received the DARA has achieved MRD negativity in comparison to only a quarter of the patients who received RD. So the results were updated in the ASH 2020 and still showing the impressive results. So after 4 years of follow-up, the PFS for the DARA RD still did not even reach to a 50%. So still it's not reached. So very impressive. We're talking about transplant ineligible patients who did not receive transplant, and more than half free of progression after 4 years. Very impressive results, I would say. So also addition of bortezomib to backbone of RD was tested in the SWOG S0777 trial, and the addition of bortezomib to a backbone of RD has resulted in both PFS improvement and as well as survival benefit. So we can see here 43 months versus 30 months, and 75 months versus 64 when we are talking about survival. So what about the very frail patient that sometimes we will see? So this trial, which was presented about a year ago by the Dutch group, looking at a different induction regimen of extramedullary, daratumumab, and low-dose dex for unfit frail patients. And as we can see here, this is the protocol that they used. And we are dealing with a very frail elderly patients with significant comorbidities. Lots of them, they have some renal impairment, very poor performance status, as you can see here, and a Charlson comorbidity index that's also showing significant frailty. Despite that, these patients, they did well, and they tolerated this therapy regimen well overall. And you can see here, overall response rate was about 3/4, with the fast time to response, as you can see here. And in terms of, and this is the overall survival, which was 12 months in 96% of the patients, as we can see here for the unfit and the frail patients. So though these are very frail patients, they did well and they tolerated therapy very well. And we can see here the hematological grade 3 or 4 toxicities was not very common. And the other non-hematologic toxicities were also not very common with this induction therapy, although the patients were tested were quite frail. Don't forget about supportive care. Important, it makes difference. So bone-directed therapy, antimicrobial prophylaxis, VT prophylaxis, PPI, growth factor support as needed, and pain management. Thank you so much, and I'm happy to take any questions.
Thank you, Mazid, for this excellent presentation and highlights from ASCO and overview of the management of the patient from upfront setting. Dear audience, please send your question through the Q&A icon. So my question, Majid, Do you think with all those trials to looking for the effectiveness of the novel medication will overcome our direction for transplant, or we are still going for upfront transplant, especially with this cardamom study?
Okay, yeah, so excellent question. So I think for high risk patients, definitely transplant is recommended. No one will talk about that, and maybe even double transplant in some settings. But for as we saw in the other trial, the cardamom, so now there's somewhat looking at response adapted approach. Okay, although I know it's different when we are talking about two different diseases, like what we are doing with Hodgkin. So you do the PET and you direct their therapy based on that. So MRD negativity makes difference in that group of patients, and patients who achieve the MRD negativity, especially if it is earlier, like pre-transplant, although there is nothing recommended, but I think maybe in the future, if we are using MRD in the right setting, in the right way, we can use it as a response adapted approach. And instead of taking all of the patient for transplant, we would select the patient who did not go into a very deep response, because we all know that transplant is not risk-free. There is risk of mortality, there is risk of secondary malignancies, risk of infertility, all of this. So plus, you know, the cost associated with it, and also the need for admitting the patient for maybe 1 month. We can do it as outpatient, but still most of the people will do it as inpatient. So I think better selection based on response and based on the risk status, I think that's what's going to be in the future.
One more question regarding the maintenance for DARA and the Cassiopeia trial. How long was it in the trial?
2 years. 2 years all disease progression.
Okay. I have here a question whether a transplant for all ages. So you can highlight on that. Simple question.
Age by itself is not the only contraindication for transplant. Usually in most of the places all over the world will not transplant patients who are above 70, except certain exceptions. If we are dealing with like very fit elderly patient, some people will take them for transplants, although the risk would be higher for that group of patients. In most of the centers, 65 would be the cut age for transplant. Between 65 to 70, you can have some exceptions. Above 70, you need to be very selective. And especially for myeloma, we are not dealing with a curable disease. So even with transplant, you are not going to cure the patient, okay? And in the presence of all of the novel agents and multiple lines. So even if the patient relapses in the future, you have other options you can consider. So the risk of mortality and complication would be higher in elderly patients.
We'll take one more question. Tandem, what do you think about tandem transplant? Is there a role?
Okay, yeah, so tandem transplant for high-risk myeloma, mainly 17p, is still considered, although there are some debate about that. So we have some published data about the advantage of tandem transplant for high-risk patients. So we would save the tandem transplant for patients with high-risk cytogenetics, mainly 17p, or the ones that I told, triple hit or the double hit or triple hit. And that based on the results of the Stamina trial, which showed that. Also, you can consider it and highly recommend it for patients with aggressive plasma cell dyscrasias like plasma cell leukemia.
Thanks a lot, Majid, for this elaboration and answering all these questions. So we'll move to the satellite symposium, and it sponsored by Janssen. And it's my great pleasure to introduce Dr. Ihab Al-Humairi. Dr. Ihab is a consultant hematologist and bone marrow transplant from Prince Noura Oncology Center, National Guard, Jeddah. Dr. Ihab will chair the session for the satellite symposium. Please, Dr. Ihab.
Thank you, Dr. Amal, for the kind introduction, and thank you, Janssen, for supporting the symposium and the organization and inviting Dr. Maria Mateus, who is very well known to our audience here in Saudi Arabia. She has given us kindly many talks in the past. She's a consultant hematologist at the University Hospital Salamanca, and she's going to talk to us today about how to manage newly diagnosed multiple myeloma with high-risk cytogenetics. Maria, you can go ahead.
Yeah, hello, Dr. Al-Humairi, and well, hello to everyone. And first of all, thanks for the kind invitation to participate in this meeting. And indeed, I've been, well, in different meetings with people from Saudi Arabia. And indeed, I visited your country, I think that 3 or 4 years ago. And I will address the topic of multiple myeloma with high-risk cytogenetic abnormalities, although I decided to include some other high-risk features. Here you can see my conflict of interest. And first of all, what is the definition of a high risk? And we can go to the definition given by Professor Barlogi, those patients not being cured, and maybe this is a very aggressive definition for high risk, and maybe the optimal one is the definition endorsed by the International Myeloma Work Group, overall survival of 2 years or less, despite the use of novel agents. What is appropriate? And we usually refer to patients with a high risk when they present high-risk cytogenetic abnormalities. But you know that there are other patient-based factors, disease-based factors that can implement or can result into high risk in patients with multiple myeloma. And the first one is the frailty. And in this study done by Professor Palumbo some years ago, you can see here how frailty is able to distinguish 2 different subgroups of patients. And in terms of overall survival, the power is higher or stronger than the chromosomal abnormalities or the chronological age. So we know that frailty is a high risk feature for patients with multiple myeloma. If we go to the conventional international staging system, you know that just with these 2 biomarkers, serum beta-2m and albumin, it is possible to identify a subgroup of patients, ISS3 with beta-2m higher than 5.5, for which the survival is significantly shorter. And this has been reproduced in young patients, elderly patients, conventional agents, novel agents, and indeed, this international staging system continues being valid. Although it's true that the next step was to try to incorporate cytogenetic abnormalities. And Professor Moreau did, well, an analysis in a large series of patients in order to identify those in which the median overall survival was inferior to 2 years. You can see here how this population is no more than 5%, and baseline characteristics of these patients included the presence of 414 translocation or deletion 17p, in addition to either ISS3 or high LDH. And this was really the rationale for the revised ISS, in which, again, as I previously told you, the cytogenetic abnormalities together with LDH were incorporated into this staging system, and it is possible to identify a subgroup of patients, ISS3, for which the survival and as well as the progression-free survival was significantly shorter. Of course, extramedullary disease is another feature that confers high risk in multiple myeloma, especially this type of soft tissue plasmacytoma, meaning that plasma cells are able to escape from the bone marrow. They don't need the bone marrow microenvironment. They proliferate in an anatomic site distant from the bone marrow, and we know that extramedullary disease is a poor prognostic factor in multiple myeloma. And a similar situation occurs for the plasma cell leukemia, either primary or secondary plasma cell leukemia. And from my point of view, plasma cell leukemia continues being an unmet medical need. If we focus more on cytogenetic abnormalities, from the classical point of view, I think that a FISH routine testing should include at least 414 deletion 17p plus 1q deletion 1p, and it is also possible to include 1416. Basically because we know that these cytogenetic abnormalities confer also high risk to patients with multiple myeloma. If other assessments like next generation sequencing would be available, it would be possible to know the mutational status for TP53. Concerning other mutations, huge heterogeneity is present, and we can check NRAS, KRAS, and so on, but we know that they are going to be present in no more than 20% of the patients, and in principle, there is not a targeted therapy for these cytogenetic abnormalities. Important to know that cytogenetic abnormalities may differ in first and later relapses because of the clonal evolution. And this is important because at the moment of the relapse, if possible, it would be recommended to check again FISH analysis in order to evaluate if some new cytogenetic abnormalities were acquired. And in the future, I think that the clinical classification combine these lesions with ISS, serum LDH, or high-risk gene expression signatures. And this is what you can see here in this slide. This is a work published some years ago in leukemia, and this is a large study done in newly diagnosed myeloma patients, included in different clinical trials as well as in the COMPASS program. And for me, what is important to see is how this analysis was able to identify a subgroup of patients, you can see here in brown, with a very poor prognosis. Indeed, the median progression-free survival was not superior to 15 months, and these patients included those with either biallelic TP53 inactivation or amplification more than 4 copies of 1q21 on the background of international staging system 3, composing no more than 6% of the population. This population will represent a subgroup with high risk, and maybe the trend towards we are moving forward is to utilize more and more these high-risk cytogenetic signatures in order to be combined with clinical markers. And these patients were identified as double hit. What are the therapeutic options we can utilize for the management of high-risk patients with multiple myeloma? And before moving into the evaluation of the different combinations, I would like to share with you 2 key messages. The first one is in patients with high-risk features, you have to try to utilize the best combination as possible, to use the novel agents-based combinations and the most effective combination. And the second important concept, to try these patients to achieve minimal residual disease negative. And this is the rationale. Many novel agents are arriving into the treatment of multiple myeloma, and we have to select the best combination. And concerning minimal residual disease negative, you can see here in this meta-analysis done by Professor Munshi and published in 2020, how MRD negativity is an important predictor for, in this case, progression-free survival. But when a patient with a high-risk cytogenetic abnormalities achieved MRD negativity, the hazard ratio for progression-free survival was similar to that observed in patients with a standard risk. And this is informing us about the possibility of MRD negativity is able to overcome the poor prognosis of the presence of, in this case, high-risk cytogenetic abnormalities. And this is also applicable to the RISS system. This is the Spanish experience in approximately 500 patients with a newly diagnosed multiple myeloma treated with RVD, transplant RVD, and maintenance. And you can see here that when patients achieve MRD negative, the prognostic or the outcome is comparable for patients with RISS1, RISS2, and RISS3. And this is not the case when MRD is positive. And in this case, you can see how patients with RISS3, the median progression-free survival is very short, only 14 months. This means that minimal residual disease negativity is able to overcome the poor prognosis of RISS3 patients, but we can isolate the cytogenetic abnormalities. And in the same study, if we focus on patients with high-risk cytogenetic abnormalities, 37% of them, the MRD was undetectable. And when the progression-free survival and the overall survival was evaluated, you can see here how the outcome for patients achieving MRD negativity is comparable regardless of the cytogenetic abnormalities, confirming that MRD negativity is able to overcome the poor prognosis of the presence of high-risk cytogenetic abnormalities. And this is the two basic concepts in order to treat the patients with multiple myeloma. If we focus first, before moving to the management of patients with high-risk cytogenetic abnormalities, we consider what I previously told you, the frailty. It's true that the frailty is a high-risk feature in patients with multiple myeloma. The incorporation of the novel agents like daratumumab to VMP or daratumumab to lenalidomide and dexamethasone, you can see here in these slides how it is able to significantly improve the outcome of the frail patients. And in the Alcyon study, there are not major differences among fit, intermediate, or frail patients when they receive Dara VMP. And when we focus on Dara Lendex, it's true that the median PFS for Dara Lendex frail patients has not been reached yet. And look at how the median PFS for Lendex in the frail population is 30 months. So the addition of Dara is able to significantly improve the progression-free survival. If we focus on other high-risk features like extramedullary disease, and it is usually more present at the moment of the relapse and non-refractory situation, a new drug, melflufen flufenamide, has demonstrated to be effective in patients with extramedullary disease. This drug has been approved in the phase 3 OCEAN study, but in principle, it works in patients with extramedullary disease. And the other possibility would be to go to BCMA CAR-Ts, and here you can see a clinical trial conducted with BCMA CAR-Ts, and some patients with extramedullary disease were included, and in principle, the response rate as well as the outcome was comparable to the intent to treat patients population. So BCMA CAR-Ts can represent also another possibility. And if we focus right now on patients with RISS3 or basically patients with high-risk cytogenetic abnormalities, don't forget to try to utilize the best as well as to try to achieve MRD negative. This is the standard of care for the management of newly diagnosed myeloma patients, in this case, transplant eligible. And the first important question is, what is the standard of care for patients with high-risk cytogenetic abnormalities? And what is the outcome when we use standard regimes for this population? And this would be the starting point in order to try to improve in this specific subgroup of patients. Here you can see one of the first clinical studies conducted only in patients with high-risk cytogenetic abnormalities. And in this study, VRD was compared with VRD plus ilotuzumab, and transplant was not included in between. And you can see here how both combinations resulted into a similar outcome. But for me, and what I would like to share with you is, if we don't include transplant and we use VRD, the median progression-free survival for patients with a high risk should be approximately 30-34 months. And if we include autologous stem cell transplantation, we have this data published by the group of Sagar-Lonial in Atlanta, and patients with high risk treated with VRD as continuous therapy, including autologous stem cell transplantation, the median progression-free survival is 40 months, the median overall survival 78 months. And from my point of view, this would be the starting point. And how are we going to improve the outcome of patients with high-risk cytogenetic abnormalities? It is possible to add the monoclonal antibody daratumumab. And this is the outcome for patients treated with DARA plus VTD in the Cassiopeia trial. And here you can see the progression-free survival. The hazard ratio for patients with high-risk cytogenetic abnormalities was 0.67, a bit higher than for patients with a standard risk, but the addition of daratumumab to VTD significantly improved the outcome for patients with high-risk cytogenetic abnormalities, especially if we compared with VTD alone in patients with high risk. What about carfilzomib as part of the induction for patients with high risk? Here you can see the Forte study, and it's true that for patients with high-risk cytogenetic abnormalities treated with KRD, it is necessary to include the autologous stem cell transplantation in order to have a good outcome for patients with a high risk, as you can see here in the blue line, for patients with high risk as well as double hit. This is another study conducted by the German group, the Concept trial, also focused only on high risk newly diagnosed myeloma patients treated in this case with KRD plus isatuximab. And in principle, all patients responded. And important to see how 60% of the patients were able to achieve MRD negative. We needed to wait in order to see how the progression-free survival evolves. Katja Weissel has presented the first analysis in terms of progression-free survival, and it's important to note that some patients progressed during the first years. So this means that this strategy is maybe effective, but definitely it is necessary to investigate more in those patients who early relapsed after treatment with the KRD plus the monoclonal antibody isatuximab. What about the tandem transplant? And I think that this question was addressed in the discussion of the previous session, and this is the European Myeloma Network study in which it was observed how progression-free survival for patients with a high risk and standard risk when they received tandem transplant was comparable. So today, tandem transplant can be applicable for patients with a high risk, and it was pointed out also the Stamina trial confirmed the benefit of tandem transplant for patients with high risk in terms of progression-free survival. However, it's important to remark that in this study, the induction was conventional induction, as well as in the European Myeloma Network, CyBorD. Would it be necessary to do tandem transplant in patients with a high risk once the monoclonal antibodies are added as part of the first line of therapy to the induction regimes? The answer is maybe no, but we don't know yet, and some clinical studies are evaluating this. Here you can see the Optimum trial, and this is another trial specifically conducted in patients with high risk features. And you can see how this is, I would say, a new total therapy approach based on VRD cyclophosphamide plus daratumumab, 6 cycles followed by transplant, 2 consolidations, Dara VRD 6 cycles, 12 cycles of Dara bortezomib and lenalidomide, before proceeding to maintenance until progression disease with Dara plus lenalidomide. The preliminary data presented at the EHA and ASCO showed how after transplant, 93% of the patients responded, 87% VGPR rate or better, and important to see how 100 days after autologous stem cell transplantation resulted in 82% of MRD negativity rate. And from my point of view, this is going to be the optimal marker in order to see how the progression-free survival evolves. And in terms of maintenance, the classical maintenance approach is lenalidomide, and we know that lenalidomide improves the outcome of patients with a high-risk cytogenetic abnormalities, but it is not able to overcome the poor prognosis. And maybe for patients with high risk, we need something else. Maybe daratumumab will be the ideal partner for patients with high risk. And this is the Griffin study, in which, as you know, RVD plus minus daratumumab, followed with transplant consolidation with RVD plus minus dara, was followed by maintenance with lenalidomide alone versus lenalidomide plus daratumumab. And what is important to remark right now here is how the MRD negativity rate in a valuable population was almost 80%, what is important, and approximately 1/3 of the patients were able to maintain the MRD negative 1 year later. We know that maybe this is going to be an excellent surrogate marker in order to predict optimal outcome for patients with high-risk cytogenetic abnormalities. And the idea would be to utilize the best combination. And another possibility would be to add the proteasion inhibitor. There are some experience with bortezomib plus lenalidomide, and in the fourth study, carfilzomib was evaluated as part of the maintenance, and definitely add something even to the patients with high risk or to the patients with double hit. If we move now to the transplant ineligible population, the situation is more clear from my point of view, because definitely DARA VMP is not an optimal regime for patients with high-risk cytogenetic abnormalities. Is able to improve the outcome of patients with high risk in comparison with VMP. But I think that there is a big difference between DVMP standard risk, DVMP high risk. And for high risk transplant eligible newly diagnosed myeloma patient, the best option is DARA-Lendex, because in terms of progression-free survival, the median PFS for patients with high risk and treated with the dara-Lendex was 45 months. And from my point of view, this is the longest median PFS so far reported in patients with high risk, newly diagnosed myeloma, and indeed transplant ineligible. Don't forget that in the Maya study, 44% of the patients were indeed older than 75 years. Before finishing my presentation, just to show you here another high-risk feature, those patients treated with an optimal combination as part of the first line of therapy, followed by autologous stem cell transplantation, maintenance with lenalidomide, but early relapse within the first year, within the first 18 months after autologous stem cell transplantation. These patients are what we can call functional high-risk patients, and we know based on this study recently published by the UK group how the outcome in terms of PFS and overall survival are really very poor for these patients early relapsing after the first line of therapy. For this population, definitely we need also novel combinations, and from the classical point of view for these patients, the option was allogeneic stem cell transplantation, utilizing reduced intensity conditioning regimes, and the outcome was not good, but we know that allo is not a curative approach. We have to consider the transplant-related mortality, and today we have to replace RIC allo by cell therapy, and maybe BCMA CAR-Ts or bispecific monoclonal antibodies will be the future. And indeed, we know that these patients with functional high risk had been included in some clinical studies with ide-cel or cilta-cel, and in principle, the response rate as well as the durability of the response is comparable to the intent to treat patient population. And I showed you before how patients with extramedullary disease responded very well. The same is applicable for high-risk cytogenetic abnormalities. And here you can see bispecific monoclonal antibodies, and some patients with high-risk features were included, and in principle, they responded also very well. But what I would like to share with you is how this is under investigation, and both ide-cel and cilta-cel are being evaluated in this functional high-risk population. look in this study how patients progressing within the first 18 months after the first line of therapy are candidates, and the cohort B of the CAR-T2 clinical study included 20 patients early relapsing within the first year after frontline of therapy. We will have very soon some data coming from these approaches, and if positive, I think that they should be in the future the standard of care for these functional high-risk patients early relapsing after the first line of therapy. Finally, well, we have many novel combinations, many novel agents, but definitely we have to continue improving the scientific knowledge, and we have to investigate, of course, in the clone of MRD positivity after optimal treatments. We can't forget the peripheral blood, the bone marrow microenvironment, and in conclusion, I think that we need to continue improving the possibilities of treatment for patients with a high risk. Conventional and novel agents improve, but do not completely overcome the poor prognosis of the presence of high risk. Areas for improvement, better identification, such as functional high risk, and generation of scientific knowledge around the high risk subgroups, new approaches, such as cell therapy that can be promising, trials focused on high risk myeloma patients, and don't forget, at least right now, that there is a strong correlation between prognosis in high risk and MRD negativity achievement. And my recommendation would be try to utilize the best combination as possible, trying to put your patients in minimal residual disease negative and sustain it over time. And I stop here. Thank you very much for your attention.
Thank you, Dr. Maria, Dr. Mateus, for this very nice and comprehensive overview of a very difficult topic. Very nice data that you've presented. We have here two questions from our audience. Dr. Binyam from the King Faisal Specialist Hospital in Jeddah is asking, you've already alluded to this before, but maybe you can elaborate a little bit more. And he's asking about the role of allo in young, fit patients who are high risk with high risk cytogenetics. Is there any role with these current novel therapies?
Yeah, so we have to try to utilize the best combinations. And in principle, for patients with a high risk, newly diagnosed myeloma patients, fit, young, we are not doing allogeneic stem cell transplantation as part of the first line of therapy. We try to utilize the best combinations to put this patient in complete response and minimal residual disease negative. And our standard of care today, if possible, is to utilize RVD. We usually ask permission to incorporate the daratumumab in these high-risk patients, followed by transplant. If after the first transplant we see that the response improved, we continue with a second autologous stem cell transplantation. And after the transplant, we do maintenance in principle with lenalidomide and bortezomib. And what I would recommend maybe the allo transplant is after this approach of therapy, the patient is in response, but the relapse will occur earlier on within the first year, within the first 18 months, young, fit patient with high-risk cytogenetic abnormalities. It is possible to utilize a novel drug-based combination, but maybe the response is not going to be durable. And this is the reason why my first option would be, of course, a BCMA CAR-T or a novel approach. But if these approaches are not available yet, the best approach would be allogeneic stem cell transplantation. Please do it, because we know that the graft versus myeloma works. The only problem is the transplant-related mortality, and we know that the patient is going to relapse. But in principle, it would be possible to do allo transplant in this patient. And even later on, it would be possible to do an BCMA CAR-T for this patient. So we have well, in my experience, just one patient, a young lady, 37 years old, treated with allo at first relapse because early relapse after autologous stem cell transplantation. She continued relapsing and she received subsequent lines of therapy. And at the end of the day, she had received BCMA CAR-T, and the lymphoapheresis was done from the lymphocytes from the donor because the chimerism was complete. And the outcome for this patient right now is very good. The CAR-T was prescribed 1 year ago in the context of a clinical trial. And this would be my recommendation concerning allogenic stem cell transplantation.
Thank you for your answer.
May I ask a question, please, for Dr. Mateos, please? So, Dr. Mateos, for a patient post allo transplant, would you give any kind of maintenance therapy? I have a patient like that now. So, do you?
Yeah, we usually wait at least the first 3 months and to see how the response is achieved, and we have to take care about the immunosuppression. So once we eliminate the immunosuppression, if we see some small M spike or the MRD continues being positive, we try to put maintenance with lenalidomide, but at very low dose, starting by 5 or 10 milligrams, and with a lot of care, because we know that graft versus host disease can be reactivated. But at the end of the day, if graft versus myeloma is also induced, this is what we want. And this is basically what we do in the clinical practice, to try to manage the immunosuppression with lenalidomide as maintenance, and even sometimes we utilize infusions of lymphocytes from the donor. But when we do a transplant, we try to exploit as much as possible the graft versus myeloma.
Thank you so much.
Any questions from other member of the panel?
Yes, if you can allow me. Thank you, Dr. Maria, for this excellent talk. My question is, outside clinical trials, are we moving to check the MRD? How and when do you recommend that? And should we individualize our therapy? My other question is for young high risk to move to 4-drug combination rather than 3-drug combination?
Yeah, concerning the first question, in routine, we do MRD, and if you don't do, or you have to select in which patient's minimal residual disease can be evaluated because it is going to be of great utility, I would say that patients with a high risk, because I showed you how in our experience, MRD negative is able to overcome the poor prognosis of the presence of high-risk cytogenetic abnormalities. And we usually evaluate no before the patient is in complete response. When the M component disappear, the immunofixation is negative, free light chain are normal, we have to go to the bone marrow, and at that moment we evaluate the minimal residual disease. If it is positive and we continue with treatment, we usually repeat after 3-6 months, depending if the patient is receiving consolidation or maintenance. And if the MRD is negative, what we do is to repeat it at least 1 year apart. If the patient is with high risk, maybe in 6-8 months, just in order to confirm that the MRD continues being negative, because this is going to be an important prognostic marker for this population. And concerning your second question, in the patients with high risk features, especially high risk cytogenetic abnormalities, I would put all my efforts in order to treat them with a 4-drug-based combination. You have to know that our standard of care is RVD, bortezomib, lenalidomide, and dexamethasone, because daratumumab is not reimbursed yet in first line in young patients. But when we have a high-risk patients, we ask to our authorities for prescribing daratumumab added to VRD. And the rationale is because these patients are young with high-risk genetic abnormalities, and we know that the better the response, the better the outcome. And our objective is them to try the best quality of the response. And this would be my recommendation. At the end of the day, not all patients presented with high-risk features and high-risk cytogenetic abnormalities are present in no more than 15% of the patients in the upfront setting.
Thank you.
Thank you, Dr. Mateos. If you allow me to ask the question, the 17p deletion, you know, each group define it in a kind of different way. What's your take on that? What do you think is considered to be a positive 17p deletion?
Well, you have to know that I am attending right now the International Myeloma Workshop in Vienna, and there has been a discussion about this. You know that the French group did an analysis and considered that it is necessary to have more than 55% of plasma cells with the deletion 17p to confer a poor prognosis in multiple myeloma. Honestly, this is not our experience, and we have a lot of patients treated in our clinical trials and in our hands when patients presented more than 20% of plasma cells with the deletion 17p, our patients presented a poor outcome. And for us, the identification of deletion 17p, I think that should be considered as high-risk cytogenetic abnormalities, and the higher percentage of plasma cells with the deletion 17p, the worse prognosis for the patient.
Is there any of these cytogenetic abnormalities that usually perform worse than the others? For example, is the 1q gain or worse than 17p, or are they all equal?
I think that the TP53 inactivation, the biallelic inactivation of TP53 throughout the deletion of deletion of 17 in both chromosomes, or deletion in one chromosome and in the other one mutation of TP53, is the poor cytogenetic abnormality. In addition, if deletion or inactivation of TP53 is added to other cytogenetic abnormalities like 414 or plus 1q deletion of 1p, we know that when more than 3 cytogenetic abnormalities are present, the prognosis is even worse. But if we have to evaluate all of them as isolated cytogenetic abnormalities, I would say that the deletion 17p is the worst.
Thank you for that.
Can you allow me for one more question? Dr. Maria, I have a patient with plasmacytoma, pituitary plasmacytoma as initial presentation, 45 years old, with no other high-risk features. How is your approach, and how you will monitor the response for that case?
Well, first and now we do PET-CT before starting treatment in order to identify very well the extramedullary disease and to know very well the uptake as well as the size of the plasmacytoma. And the second approach, it depends where the plasmacytomas are, in the liver, in the skin, or just
pituitary.
Sorry?
In a pituitary gland.
Okay.
Yeah.
But multiple plasmacytomas, I can imagine.
Yes, yes.
Yeah, so there are two possibilities. One possibility is to treat as conventional therapy with PI, IMID, plus, if possible, the monoclonal antibody daratumumab. But honestly, if the extramedullary disease is pure extramedullary disease, sometimes from my point of view, I would prefer to go to BDT-PACE or something like that, including bortezomib, IMID, and conventional chemotherapy, because we know that maybe this works better to destroy the pure extramedullary disease.
Is there a role for radiotherapy in that area or no?
Yes, so maybe you have to contact with the radiotherapeutics in order to see if it is feasible. But of course, there is also a role for radiotherapy in multiple myeloma. It's true that when extramedullary disease is present, some people say that this means that the plasma cell is traveling from one to another site, and local radiotherapy is not enough, but I think that as complementary treatment, it is feasible and it is possible.
Thank you.
I think with that, we will close this satellite symposium, and I would like to thank Dr. Mateus for very nice and thoughtful talk, and for her answering all our questions. Thank you very much. And
thank you
Jansen.
very much. Yeah, thanks.
So thanks, Johnson. Thank Dr. Maria. Thank Dr. Ihab for this excellent discussion. We'll continue our webinars with the third speaker in the webinar, Dr. Bassem Beiruti. Dr. Bassem is a very well-known hematologist. He is a consultant hematology and bone marrow transplant from King Faisal Specialist Hospital, Jeddah. He is the acting chairman of Department of Oncology there. And he has also a special interest in multiple myeloma. Dr. Bassem will talk about update in amyloidosis management, which is something rare we hear about in many presentations. So please, Dr. Bassem.
طيب بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيد الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم تسليما كثيرا. Thank you, Dr. Amal, for the nice introduction. Actually, I'm not anymore the acting chairman. Finally, they found a real chairman. So we have Dr. Wasil Justani. He is the chairman of the oncology department. We welcomed him last week, and we will carry on our duty toward our patient with a new leader. It was really tough years for me to lead this very huge department. So I will focus now on hematology, which is easy for me, and with my favorite disease. So my topic is amyloidosis, and it's one of my favorite diagnoses and diseases. Although it's rare, but I think it's more than that what we can expect. I have no conflict of interest. I didn't get any of the slides from any of the company. All these slides are my efforts. So we will start with a case presentation. Mr. V is 78 with past medical history of bypass surgery for his heart type 2 diabetes, hyperlipidemia, hypertension. He's ex-smoker, and he has psoriasis, and he had this light chain disease. And the bone marrow biopsy confirmed focal lymphoid aggregates consistent with monoclonal gammopathy, negative for overt plasma cell dyscrasia, because the workup initially was for multiple myeloma, and he had prostate cancer in the past. So he is on these medications that are known. So he presented with these symptoms: weight loss, fatigue, 6-month history of bilateral paresthesia of the hands, bilateral waxy, red plaques, hemorrhagic at time around the eyes, and the review of system was unremarkable. And if you will examine him, he would have this periorbital bleeding and the big tongue or macroglossia. So bilateral mandibular swelling, which is related to salivary gland, hepatomegaly, and positive tunnel test and Fallon test for carpal tunnel syndrome. His lab showed a hemoglobin of 12.3, normal MCV, white count 6.4, normal differential, normal electrolytes, creatinine, kidney, liver. And the biopsy showed the congruent normal light, but with the congruent polarized light, you can see that there is amyloidosis. And that's important message always to deliver to our pathologist. Unfortunately, that's tricky, because if you don't tell the pathology, because here we did the bone marrow, there is monoclonal infiltrate in the bone marrow. Yes, but if you don't tell the pathologist, please do congruent, they will not. If you don't do congruent with the polarized light, you will miss the diagnosis, and that's a problem. But what helps us here is the clinical presentation. However, these clinical presentations are rare. You don't see it all the time. So amyloidosis, I will ask SSPD to give me the opportunity to present the full-blown picture, because I can tell you many of the medico-legal cases in literature and in real life are amyloidosis related after, of course, vena thromboembolism. So amyloidosis is a rare disease, 8 cases per 1 million per year. It's extracellular deposition of insoluble fibrillar proteins in organs and tissues, and classified as primary AL, which is a hematological or plasma cell dyscrasia or disease, and the familial or secondary, like secondary to rheumatoid, osteomyelitis, chronic inflammation, infection that will lead to secondary amyloidosis. And that will be treated by the primary service. Treating the underlying cause will prevent the complication. The pathogenesis is really related to the deposition of this abnormal protein that is difficult to eradicate and will affect the organ function at a slow rate. So most frequent light chain variable region, less frequent constant region. So, but usually it's light chain, and that's an important lesson for us in diagnosis. You have to request serum-free light chain, urine-free light chain in order to pick up that there is possible amyloidosis. Second, when you do any biopsy, especially liver, kidney is very, very vital to ask for Congo red to be able to pick up the light chain deposition disease. And usually it's lambda more than kappa. 5 to 10% plasma cell in bone marrow. So that's the typical story. And by the way, amyloidosis can coexist with multiple myeloma in 10% of the cases. So that's another diagnostic dilemma, that when you have the patient with multiple myeloma, but there are abnormal findings, think of amyloidosis, please. The differentiating amyloidosis from multiple myeloma is sometimes difficult. Amyloid clone, usually indolent, small size, plasma cell clonality, not always apparent. You really need the monoclonal, the light chain lambda. 10 to 15% with multiple myeloma, they coexist with AL amyloidosis. The Mayo Clinic experience last century, out of 1,500 or 1,600 patients with AL amyloidosis, 6 progressed to multiple myeloma in 10 to 81 months. So it's again another diversion that myeloma can coexist with amyloidosis. Amyloidosis patient can progress to multiple myeloma as per the Mayo Clinic experience. None has cardiac or hepatic involvement at initial diagnosis, and that's another lesson. If you delay the diagnosis of amyloidosis, that's the end results. Many of the cases with cardiac amyloid, they have the disease diagnosed late, usually in cardiology clinic or nephrology clinic or neurology clinic. These patients, they have been having these symptoms for years. And if they survive long enough, they will develop, these patients will develop multiple myeloma. The clinical presentation, virtually every organ except CNS, central, not peripheral, most common kidney and heart, fatigue, weight loss, macroglossia, highly specific, present in 9% of the patient. So that's it's rare incident compared to kidney. Typical presentation is nephrotic syndrome, proteinuria. So I wish our colleagues in nephrology, when they had these cases, don't start steroid. That's number one. Please, when you do kidney biopsy, please send for Congo red. The problem, if you start steroid, you might mask multiple myeloma. If you don't send for Congo red, in the kidney biopsy, you will miss the disease. Rarely, these patients, they will end up with end-stage renal disease, hemodialysis, or systemic hypertension, unlike the case of multiple myeloma. The cardiac manifestation of amyloidosis is restrictive cardiomyopathy, thickened myocardium, diminished A wave, atrial thrombi, even with sinus rhythm. So that's a clue that there is amyloidosis here. ECG low voltage and pseudo-infarct pattern. That's the pattern. You see low voltage ECG and the pseudo-infarct, that there is ST depression, ST elevation, T wave inversion, suggestive of ischemic, but the reality, this is one of the manifestations of cardiac amyloidosis. Autonomic nervous system, 20% posture hypotension, GI dysmobility or dysmotility. So many of these patients with GI symptoms think of amyloidosis. If you do biopsy and there is collagenous colitis, it's one of the differential. So please inform the pathology to congregate for collagenous colitis. Sensory neuropathy, 40% carpal tunnel symptoms, and motor is rare. Hepatomegaly, infiltration, and could be related to congestive heart failure. Hypothyroidism, 10 to 20%. And pulmonary amyloidosis and hypoadrenalism are rare, but they are part of the presentation. Raccoon eyes, these are typical, but very, very rare. Factor 9 or factor 10 deficiency or deposition in the splenic, another hematological presentation with bleeding. And again, it's very rare, very rare. That's the typical of the submandibular glands, and that's the typical of the shoulder pad, or because of the deposition of the amyloid. Diagnosis, you really need to do the congregate and do this pathognomic red, green bifringence under cross polarized light. It's a gold standard. Sensitivity has 80 to 85%. Immunofixation, erythropoiesis, 85%, and that's important to look for the serum-free and urine-free light chain estimation. Bone marrow sensitivity reach 90%, but you have to tell the hematopathologist, if you combine the bone marrow with the subcutaneous abdominal fat, you can get sensitivity up to 90. Actually, some reports said 100%. The point, if it is negative one time, you have to repeat if you suspect amyloidosis. And if you repeat 3 times, you will get it 100% sensitivity. So just consider doing bone marrow. If you do bone marrow, ask the hematopathologist to do congregate and the polarized light assessment and the subcutaneous fat. The gingival biopsies, risk of bleeding, rectal biopsies, risk of bleeding also, but they can really add in these diagnosis. And that's the typical light chain showing light chain kappa band. So that's serum-free light chain assessment. And that's the Congo rate. Prognostic factor, median survival, 18 months. This was last century, by the way. I'm talking, I am among the people who lived through 2 centuries, so 20th century, 21st century. So we can talk about last century. So the survival in the last century was 18 months. It is 6 months with cardiac involvement. Mayo Clinic, they had their experience. Robert Coyle is famous as a pioneer in the plasma cell dyscrasia. They published 841 AL amyloidosis. Survival 51% at 1 year, 16% 5 year, 4.7 at 10 years. So many of these patients, they succumb with their diagnosis and die because of the complication of amyloidosis. All 10-year survivals, 30 patients only out of 800 received alkylating agent, which was the standard of care in the last century compared to 21st century. All responded to 14 patient absence of M protein, serum, and urine. 10 patients with nephrotic syndrome had objective responses. Bad prognostic factors, heart failure, old age, creatinine, bone marrow plasma cell, more than 20%, platelet less than 150, and peripheral neuropathy. So all these, if they are present, they are poor prognostic. In Italy, they had this degree of plasma cell clonality inversely proportional to survival duration. Treatment 3 regimen, primary amyloidosis, colchicine alone, melphalan and prednisone, and melphalan, prednisone, colchicine. This was New England when I was in training. It's called CMP, randomized clinical trial at Mayo Clinic. They had 220 patients, and the intervention was colchicine, melphalan, with prednisolone, or the triple colchicine, melphalan, prednisolone. And they were monitoring these patients for adverse event and the outcome, duration of survival, treatment response. And the main results, median survival, colchicine alone 8 months, melphalan, prednisolone 18 months. Adding colchicine to MP was no difference. So we are back to square one of melphalan, prednisolone as the standard of care in the 20th century. Subgroup analysis, heart failure, 5 months, nephrology, 16 months, peripheral neuropathy, 34 months, and others, 15 months. So really, the heart failure is one of the poor prognostic marker for amyloidosis. So conclusion, there is no role of colchicine in management of primary amyloidosis. And that was the end of the century, last century, with a broken heart. There's nothing on the horizon. Usually people will break in tears when they have this diagnosis. There is nothing on the horizon. And the other treatment failed, if the patient failed treatment, they will go for palliative high-dose DEXA and intense chemotherapy. This started last century. So during my training, we did the transplant, auto-transplant for patients with poor prognostic. The worst group is the cardiac transplant. We had 6 patients, non-transplant, cardiac non-transplant, and 9 patients cardiac transplant. Actually, the study, this is the single, institution, single high-dose melphalan, like the transplant for multiple myeloma, 19 patients, 2 died following the transplant, 3 months, 11 complete remission of plasma cell dyscrasia, organ function, 6 improved, 10 stable, 12 months, 8 improved organ, 1 deteriorate, 24 months, 2 still in CR of plasma cell dyscrasia. So it was a positive study in transplant. Then the PS341, which is the proteasion inhibitor. This is vincristine, adriamycin, dexamethasone rescue, and dexamethasone interferon. These were the transplant caveat for multiple myeloma. This was before the Dr. Majid Al-Ahmadi was born. So just for his history, it's important to keep track of the history a moment. So summary of the amyloidosis last century, plasma cell dyscrasia, monoclonal light chain, lambda more than kappa, infiltrate every organ, tissue except CNS, consider more than 40-year nephrotic syndrome, heart failure, hepatomegaly, peripheral neuropathy without obvious etiology, think of amyloidosis. Diagnosis congruent, immunoelectrophoresis, immunofixation, bone marrow biopsy. If you add to it subcutaneous fat, it will improve. And baseline liver function, ECG, echo, all this involvement, and the prognosis is really poor, and treatment is really non-promising. Now we are 21st century, happy century, happy new year. We have now plethora of new data handling and presenting. So what I did, I reviewed this EHA ASCO, and I will present upfront transplant, that's the standard of care nowadays. And then the proteasome inhibitor, we have different one. The first one is bortezomib, then carfilzomib, then ixazomib is the oral one. IMID, really, they added also to the care of these patients. Monoclonal antibody, daratumumab is really added to the care of these patients. And then the combo, the Andromeda trial, where they compared 4 drugs. Dara is approved in January 2021, and the update was presented in ASCO 2021. It's an approved therapy for newly diagnosed patient with the amyloidosis. That's the ASH algorithm, how we really diagnose, do risk assessment, response assessment, and follow up. It's important to not go through it. I did emphasize on the importance of really thinking of amyloidosis, doing the congruent and the polarized light assessment, doing the combination, ask our colleague hematopathologist to do, request the serum-free light chain. It's very important test, urine and serum, and so on. So do I need to present that CAR-T is coming as a therapy for? So in transplant, we trust others should show data. So others we will talk to about the proteasion inhibitor. This is the tourmaline AL1 study, which is the proteasion inhibitor oral for amyloidosis. So this is the results of the interim analysis of phase 3 tourmaline study, AL. And it's comparing ixazomib and dexamethasone versus a physician's choice of treatment in relapsed refractory systemic light chain amyloidosis. And although ixazomib and dexamethasone did not significantly increase the overall hematologic response rate relative to the choice of physicians, it's, I think, lousy study if you want to look at it scientifically, but the merit that really ignited that there is oral therapy that can give good quality of life to these patients. So did not meet the primary endpoint, all-time event data for favor ixazomib with dexamethasone. So I do have, not me, I used to have it, but now he is with Dr. Binyam. There is one patient, Dr. Binyam is following, and he was on ixazomib, and I think he is still on ixazomib oral therapy for AL amyloidosis. And that's the study that they compared the 168 patient relapsed refractory AL amyloidosis with major organ involvement, cardiac and renal. These are the worst group of patients, failing 1 to prior lines of therapy. They were enrolled at 68 sites. So you can imagine how rare this disease across 19 countries in Europe, North America, Latin America, Asia, Pacific. Patients could have prior exposure to proteasion inhibitor, but they should not be refractory. That's very important. Patients were randomly assigned 1-to-1 to receive oral ixazomib 4 milligram day 1, 8-15, plus dexamethasone 20 milligram day 1, 8-15, 22. So these are or physician choice, whether dexamethasone with or without melphalan, cyclo, thalidomide, lenalidomide, all these in 28 days. 28-day cycles until progression or toxicity. The first primary endpoint, hematologic response rate, was the only endpoint formally tested for the interim analysis. Second primary endpoint was 2 years vital organ deterioration or mortality rate. And that's the results were not promising, but it is really favored an oral palliative intent therapy for patient with AL amyloidosis. So it wasn't positive, but it really addressed feasibility and non-inferiority, I will say. The IMID is another group oral therapy. That's something beautiful. Most of our patients, they don't like to come to the hospital treatment area, so they really love the oral therapy. This is the long-term outcome of IMID-based trials in patients with immunoglobulin light chain. It's a pooled analysis because, as I said, it's rare disease. You cannot do what they are doing in multiple myeloma. They have really good number, 400, 500 in clinical trials. So here they pooled the data because of the rarity of the disease, makes randomized studies challenging. They pulled the 3 phase 2 studies of immune modulating drugs to update survival, toxicity, and assess new response progression criteria. Studies included were lenalidomide dexa, Lindex, cyclophosphamide Lindex, and pomalidomide dex. And that's interesting to see that even POMA can be used in these patients. Primary endpoint was hematological response. Overall survival was calculated from registries. registration to death and progression-free survival was calculated from registration to progression or death. Hematologic cardiac renal response progression was assessed using the modern criteria. Analysis included 101 patients with a median age of 65, 61% male, 37 newly diagnosed, 64 relapse refractory, median follow-up was 101 months. So interesting, 101 patient, 101 months, range 17 to 150, and 78 patients, 78% of the patients died. Of course, it's very difficult disease to start with. The overall survival and the progression-free survival for poor cohort were 31 and 15 months, respectively. 48 patients achieved a hematological response. For newly diagnosed 10 patients, 28% achieved more than very good partial response, and 14% among the relapse refractory. One cardiac stage was prognostic for overall survival. Common grade 3 toxicities were hematologic fatigue, rash, and so in conclusion, IMID can result in long-term progression-free survival, intervals, survival with tolerable toxicities, and the new response progression criteria were rapid and allows for tailoring of therapy. I will jump, I will not address the monoclonal antibody, so we'll go to this combo. So this is another randomized clinical trial, phase 3, but open label, funded by Janssen. I got this slide from myself, not from Janssen. So this is addressing upfront the Andromeda study, addressing systemic amyloidosis is a plasma cell deposition. Okay. The Andromeda study showed that the addition of subcutaneous daratumumab to the standard of care, a combination of bortezomib, cyclophosphamide, and dexamethasone was superior to Velcade, cyclophosphamide, low-dose dexamethasone alone, with high rates of hematological complete response and accessible safety profile. So this protocol, the quadruple, was approved as newly diagnosed for AL amyloidosis, January 2021, and the update was presented in ASCO 2021. And here they had randomized, open label, active controlled phase 3 study, adult patient with newly diagnosed amyloidosis. It's 1-to-1 DARA VCD versus VCD alone, 28 cycles. The bortezomib dose is known. DARA dose is weekly, and then for cycle 1, 2, and then every 2 weeks for cycle 3 to 6. After cycle 6, patient in the DARA VCD received DARA subcutaneous alone every 4 weeks for up to 24 cycles from the first dose. Disease status was evaluated every 4 weeks, cycle 1 to 6, and every 8 weeks, cycle 7 and forward. The primary endpoint was overall hematological CR in the intent to treat population. Secondary endpoint were major organ deterioration, progression-free survival, organ response rate, time to hematological response, survival, and safety. And of these 388 randomized patients, 195 were randomized to this DARA VCD, and the remaining were the VCD. And duration, as of November 2020, median treatment duration was 18.5 for DARA VCD versus 5.3 for VCD, and 78%, 40% in the DARA VCD were still on treatment. That's very important, big difference between 18.5 and 5.3, and still patients, they are on treatment. Overall hematological response CR rate continued to be higher with DARA VCD than VCD, 59% versus 19. And the more patients achieved a very good partial response, of course, with DARA VCD, 79 versus 50%. Among responders, the median time from randomization to very good partial response was shorter, of course, with the DARA VCD. Cardiac response rate were higher, and that's very important outcome. In the DARA VCD, at 6 months, 42 versus 22, and at 12 months, 57 versus 28. And renal response, again, was higher, significantly, I would say, 54 versus 27 at 6 months and 57 at 27 at 12 months. So a total of 71 deaths occurred in the DARA VCD 31 and VCD 40. the overall survival, there is no difference. And the no grade 3-4 treatment adverse event occurred in the DARA VCD, and that's very important to keep in mind. There were no systemic administration-related reaction with DARA VCD after cycle 6, and analysis of major organ deterioration progression-free survival will be updated after 200 events have occurred. And the updated result from Andromeda study reinforced the clinical superiority of DARA VCD over VCD in patients with newly diagnosed AL amyloidosis. And based on its recent approval, DARA VCD represents a new standard of care in AL amyloidosis clinical trial. Thank you very much. I'm done, Dr. Amal.
Yeah, thanks a lot, Dr. Basim, for this elaboration and excellent highlights over the amyloidosis. Please submit for the audience, submit your question through Q&A icon. So the first question is from Dr. Binyam. It's regarding how can we choose the patient for auto transplant? What's your recommendation, Dr. Basim?
You don't choose. It's an obligation. Any patient with amyloidosis who is fit for transplantation, you should do auto transplant. And that's, I didn't present the data because that's not, but it is beyond the question. I will consider all patients with amyloidosis. Actually, recently I had one patient diagnosed and I told her you should have transplant. She got the access to go to my clinic. They did transplant for her. So I think it is, it's a standard of care in all lymphoid malignancy, especially plasma cell dyscrasia. Upfront transplant is in favor of patient, unless you, Dr. Binyam and Dr. Majid, and Dr. Amal, show me evidence not to do upfront transplant in this plasma cell dyscrasia. Yeah.
Thank you. Actually, I come through one patient who was cardiac amyloidosis, and he go through the center. It was a big center in London. I can't recall the name, but we suggested for him transplant here, and he was never transplanted. He received several. They did not recommend that, and I don't know why was that, but he goes through several lines. He died after several years, but I don't know whether it will affect if we go upfront transplant. I agree with you. I recommend transplant. My question is regarding the 4-drug combination that you elaborate on. And still we are questioning the 4-drug regimen for myeloma. So do you think we should go for amyloidosis, or what's your
Absolutely,
thought?
based on the evidence. Yeah, even for myeloma, I will leave it for the myeloma experts, but 4 drugs, especially DARA subcutaneous, it's really something additional. The worst, I will not say the worst, the nightmare that you will have when you have a young myeloma patient and he or she is relapsing or progressing on your first line therapy, whether BRD, VCD, or whatever. That's our nightmare, wallahi. So the earlier you hit the myeloma and you consolidate with transplant and you consolidate with the DARA and maintenance afterward, whether IMID or Velcade, depending on the risk factors, you will be able to control the disease. As Dr. Majid mentioned, it's not curable, and I agree, unfortunately. However, I mean, lifespan of myeloma last century, before Dr. Majid was born, it was only maximum 3 years, 9 months to 3 years. 21st century with the advert development of transplant and these new therapies, the plethora of new therapies, now the patient with myeloma, they are living 18, and I had one patient from Riyadh, King Faisal Riyadh, they transplanted him, and he lived 18 years after myeloma.
So another question from Dr. Binyam, what investigation would you do to rule out cardiac amyloidosis?
You know, it's very, very challenging, wallahi, Binyam. You know this story. I mean, ideally you should do biopsy, and you go to cardiologist, they don't have the courage to do the biopsy. And then there is a specific scan. It's available in UK, but I don't know why they are not giving us this. It's called the protein-specific scan. That's available in UK, and you can really do the scan, and you can. It's like PET CT. But there is a specific monoclonal scan that you can really pick the amyloid. But I think cardiac biopsy is important. Then relying on these features, infiltrative diastolic dysfunction, this will be late manifestation of amyloidosis. Our aim to do early diagnosis, early treatment. But between me and you, we consult cardiology, they say negative, we consider patient as positive and we'll take all the precautions, meaning fluid monitoring. In the trial, when I was in Toronto, the Dr. Stewart, Dr. Majid knows him. We put these patients, the 9 patients for auto transplant for cardiac amyloidosis in ICU, and we put lines because you give them more fluid, they go into pulmonary edema. You give them less fluid, they go into hypotension. So it was really a challenging experience, and we went through. But honestly, Binyam, I will say, consider that they do have amyloidosis. Maybe they have cardiac amyloidosis. Our drugs, they are not nephrotoxic, meaning you don't need really to work on it's not like you are going to use carfilzomib where there is a cardiac toxicity and you will be concerned. So I will consider it is there. We don't need to go through cardiac biopsy if we don't have our colleague feeling comfortable in doing the cardiac biopsy. Yeah.
Any question from the panel? If we didn't have any more question, I would like to thank Dr. Basim and all the panel for being with us today. And for whom did not attend early, Dr. Saud is apologize for his presentation, Saud Al-Haili, for his presentation to an eventful social event. Sorry for him. And thanks for all audience. Thanks for being with us during your Friday holiday. And we are inviting you for our next session or next webinar next Friday, inshallah, on 17th, which will be about lymphoma and chronic lymphocytic leukemia. Have a good night and thank you all.
Yeah, and